Okay, so after the last section, we should know three methods of closing the gate and reducing pain. One of them is ascending, so ice, TENS, those sort of things. Descending, either endogenous opioids or exogenous, which we'll talk a little bit later. And emotional or other things that are going on that basically can distract you from the pain. So those are three methods of sort of closing the gate and reducing pain. Now we're going to talk about the characteristics of pain, or the signs and symptoms of pain. So in the first chapter, we talked about signs and symptoms. Signs are things you can measure or observe. Symptoms are things that the patient is going to report. And so pain has both signs and symptoms. So pain is a real sensation. No matter what, always know that your patient's pain is real. Even if they don't have any physical evidence of pain, they are still feeling pain. So just honor your patient in knowing that their pain is real. It's a real sensation, but its subjective symptoms are perceived differently by each individual. So a lot of times we are trying to paint a clinical picture. We're trying to get the patient to give us some details that will help in diagnosing the severity and cause of the pain. So of course we want to know the location of the pain. Is it in a single defined place? Is it diffuse or over a broad area? We want to use descriptive terms such as aching, burning, sharp, throbbing, widespread, cramping, constant, periodic, unbearable, moderate, severe. So all those things can describe somebody's pain. And I think all of us probably can relate to, like, we know what aching pain feels like. We know what burning pain feels like. We know what sharp pain feels like. So a lot of those things, even though it's a subjective description, we know what that is. So we're trying to, basically we're trying to describe something that nobody can know what somebody else's pain is feeling like, but we're trying to figure it out. So a lot of times when people are talking about certain types of pain, they can be associated with certain causes. We want to ask our patient about the timing of pain or its association with an activity. So certain movements, certain, like if we touch you, does it hurt? If you move like this, does it hurt? Does it hurt when you lie down or sit or stand or walk? Does it get better if you lie down or sit or stand or walk? So the timing of pain, what's its association with activities? And then the signs, so those are sort of the symptoms of pain. The signs of pain are the physical evidence of pain. So the patient may be demonstrating a stress response, like they're pale and sweaty. Their blood pressure might be higher, their heart rate might be higher, so they might be experiencing tachycardia. Those can be physical evidences of pain. A lot of times when people go into the emergency room with pain, their blood pressure is through the roof because they are in pain, and that's one of the physical signs of pain. Nausea and vomiting can be a sign of pain. Depending on the type of pain. Fainting and dizziness may also occur with acute pain. Anxiety and fear are frequently evident in people with chest pain, but they might be present in other pain situations as well. So a lot of that has to do with cultural and societal norms that apply to that person. So I was talking about my dad being a walk it off dad. It's in some cultures or societies, it's not considered okay to talk about pain or to show pain. You might have anxiety or fear about that. You never know. Sometimes you're looking at physical signs like clenched fists or rigid faces, restlessness, like someone just can't sit still, that constant motion, guarding an area to prevent stimulation of receptors. So a lot of times in people who cannot accurately report their pain, we might see some of these signs of pain. So it might be someone with dementia or someone with aphasia who can't vocalize their pain, or it could be a young child who can't really vocalize their pain. So for a long time, it was thought that newborn babies, because they had immature nervous systems, didn't perceive or experience pain. It's now been established that young infants and their undeveloped nervous systems do perceive pain, and they respond to it physiologically with tachycardia and increased blood pressure, as well as facial expressions, withdrawal reflexes, and that sort of thing. So that baby's mad face, pain face, adults do it too, but a lot of times in babies, that's all you've got to go by. There are great variations in developmental stages and coping mechanisms of children. There's a huge range of behavior, including like flailing arms and legs, resisting comfort measures, physical rigidity. So children might find it difficult to describe their pain verbally, but you have to look at their physical and physiological responses. Some children are old enough that they can do like the smiley face, frowny face scale, but some are not. There have been some pain scales that have been developed to try to capture children's pain. So it's kind of an interesting area. And we'll talk about some alternative pain scales that don't involve the patient verbalizing their pain. So comparative pain scales, you probably have heard this either in the setting that you work in or as a patient, you've heard it. They say, oh, give me a pain number from 1 to 10, 10 being emergency room pain or 10 being the worst pain you've ever felt. For a lot of people, that is very difficult to pin down. And you'll also get subjective ratings in comparative pain scales that do not coincide with what you're observing physically in signs. So sometimes you'll ask someone that and they'll go, oh, 10 out of 10. Like they don't appear to be in pain. And so often I note that in the chart. I'll say patient reports 10 out of 10 pain, but does not appear to, does not have any overt pain behaviors or something like that. That doesn't mean they don't have pain. That just means that's their pain. So the comparative pain scales are very personal. The Mankowski pain scale I really like. We'll revisit this again in 111 next fall. It equates each number from 1 to 10 with ability to do daily activities and whether or not mild or strong pain medications relieve the pain for any amount of time. So I feel like that helps people pin it down more than just giving them a 1 to 10 scale. The FLAC scale is a scale that's been developed for people who might not be able to verbalize their pain. So FLAC stands for face, legs. I can't remember what FLAC stands for. I'll write it down and I'll tell it for you. But anyway, it's consolability and crying. It's face, legs, arms, consolability, and crying. And so is their face scrunched up? Are they flailing their arms and legs? A is activity, it's not arms. Can they maintain an activity? Consolability, can you console them and kind of talk them down a little bit? And crying, are they crying? Or they, and I've seen people who were in what I would objectively, from my point of view, rate as 10 out of 10 pain, where they couldn't hold still, they were crying, they were begging you to take the pain away. That to me is 10 out of 10 pain. One time I had like a cramp, the leg cramp in the middle of the night, and I couldn't say anything. The only sounds I could get out were ah, ah, ah. And I remember thinking like, oh, this is what 10 out of 10 pain feels like. And then my second thought was, wow, if this doesn't stop soon, I'm going to have my husband take me to the emergency room. But luckily I walked it off and it stopped soon. So, but that was the thoughts that run through your head. I couldn't say anything, but I was thinking, oh, so this is what 10 out of 10 pain feels like. My little fine art pain scale here, I actually have a copy of this posted in my office. So lots of different pain scales. I'm amused by funny things. There's another one where it's sort of a humorous stick figures pain scale. I don't usually show this to my patients, but I share it with my colleagues. But some of the alternative pain scales can sometimes help patients figure out more where their pain lies. So referred pain, a lot of times it is difficult it's a pain stimulus that can be localized to a specific area, but the source of the pain is difficult to determine. So with the real definition of referred pain is that pain is perceived at a site distance from the source. So it's referred pain is typically characteristic of visceral damage in the abdominal organs or a heart attack or ischemia in the heart. So we've all probably heard that a common symptom of a heart attack is left arm pain, which is referred pain. There's nothing wrong with the arm. The pain's being referred from the heart. So this little chart sort of shows areas in the body where you get typical pain referral from specific visceral organs. Referred pain really occurs when the sensations of pain are originating in a deep organ or muscle, and it's perceived on the surface of the body in a different area. So we'll talk about actual physical mechanisms in the synapsing neurons in the spinal cord in neurology. But for now, just knowing that referred pain is pain perceived at a site distant from the source, and a common referral, you can map common referral from specific organs. So phantom pain is pain or another sensation such as itching or tingling that occurs usually in adults following an amputation. So someone that I know was in a car accident and had a below knee amputation, was a friend of the family, and he had a prosthetic leg, and if he didn't tell you about it, you wouldn't know when you see him walking around. But he said that he would get home at night after work and both his feet would hurt, even the one that wasn't there. So he said those sensations were the same as when he had 2 feet. Both his feet would hurt. So it's usually, sometimes phantom pain can be debilitating, and it usually doesn't respond to common pain therapies. Sometimes it resolves within weeks to months after after the amputation, and sometimes it doesn't. It's not fully understood. There are some interesting developments in treatment for phantom pain, including mirror therapy and light box therapy, and some other really interesting things on the horizon in pain management. So that's just an interesting area with phantom pain. So if you work with people with amputations, you might be working with phantom pain. And I do actually work with a lot of people with amputations. And so I've been lucky enough to observe this phenomenon. So pain perception and response varies from person to person. So pain tolerance is the degree of pain, either its intensity or its duration, that's endured before an individual perceives it as pain or takes some action. Like you might You say like, oh, that kind of hurts, but not enough for me to do anything about it. Um, Sometimes your pain tolerance can be increased by endogenous endorphin release, endogenous opiate release, or your pain tolerance might be reduced because of fatigue or stress. And it's going to vary from person to person in different situations. So pain perception and response are subjective, and they depend on the individual. You can't really compare it from person to person, but you can compare it from day to day in the same person. So in some cultures or some groups of people, um, in general approach pain with stoic acceptance. Some people respond to pain, some groups, with sort of loud crying and wailing, that sort of thing. So it doesn't mean that the stoic group has higher pain tolerance than the other group. It's just that some things are the culturally accepted norm. So sometimes prior unpleasant experiences and anticipatory fear or anxiety can lower someone's pain tolerance and magnify the extent of their pain response. The other thing that can magnify a person's pain response is neurological sensitivity syndromes, which we'll talk about more later. But anxiety, fear, and stress can increase the severity of pain because the central nervous system is at a heightened level of awareness. So the central nervous system is hyper aware. The way I say it is your normal pain response is like your home alarm. It goes off and there's some response to it. If your alarm keeps going off, your neighbors are going to say, what is wrong with that house? So you get the neighbors upset. So say your back hurts, and so that's your house alarm going off. It's telling you something's wrong. Maybe you should stretch. Maybe you should shift position. If it goes on for a long time and it keeps happening, maybe your legs start to hurt. And say, wow, now my back hurts and my legs hurt. And what a lot of people see in this is they go, oh my gosh, it's getting worse. But really what's happening is the whole area is getting sensitized. Then the brain starts to say, well, I better keep very close track of that area because something's going on down there. And you might even get elevated pain levels because of that heightened awareness. If then it's accompanied by stress and anxiety and fear, then it can bump your pain levels up even more. So lots of things can alter your pain perception and your response. And so sometimes what we're doing in physical therapy is we're educating people about their pain response to try to ramp that back down. So very interesting area of therapy, chronic pain management, and neuroscience of pain education.